When children do not achieve their developmental milestones at the right age as expected, it sets them up for further difficulties in learning and functioning. If the difficulties are severe enough, it can mark the child as having special needs. Good day. I am Dr. Cindy Canseco-Liego, a developmental and behavioral pediatrician, and this lecture is an introduction to developmental disorders. In this lecture, we will define developmental disorders and discuss the manifestations of some of the most prevalent disorders. We will also discuss some tips for developmental promotion. This is Eric, and he's 3 years old. He's hyperactive, does not respond when called and when instructed, has poor eye contact and interaction, but is able to name colors, shapes, and letters, although he does not communicate his needs. He also likes to collect yellow pencils and then line them up. So is this a child with special needs? Isn't hyperactivity normal among toddlers? In developmental and behavioral pediatrics, we talk about a spectrum of severity. Most developmental and behavioral manifestations reflect a range from normal to disordered conditions. On one end of this spectrum, or range of severity, is the normal variation. On the other end is the disorder, and in between these two is what is called a problem. Let's define each one of these. Variation is within the range of expected behaviors for the age and is unlikely to cause serious impairment of functioning. An example of a normal variation is a child's preference for play. So most kids under the age of 8 or maybe a little bit older would like to play a lot, and when they play, they can be quite hyperactive. So that's not necessarily a problem or a disorder. When we say that it's a problem, it's already causing some impairment or dysfunction, but short-term management is usually effective. So problems may arise with changes in environment or an increase in stress, such as when a child is moved to a bigger school, or there is heavier workload in school, or there is child and teacher mismatch. So the child can become the most hyperactive in the classroom, but after a few months of adjustment to the classroom expectations, this problem minimizes. When we call it a disorder, it's now causing serious developmental difficulties and dysfunction, and it's enough to fulfill criteria for a disorder. Health referral and comprehensive evaluation is indicated. So how do we define disorder? Developmental disorders are further defined as a group of disorders whose common factor is a dysfunction resulting from atypical brain development that manifests in childhood and that has a chronic course with a high likelihood of functional limitations. For many developmental disorders, how we diagnose it is not through biologic means such as laboratory tests or neuroimaging, but through behavioral definitions. So where do we find these behavioral definitions? We usually refer to the Diagnostic and Statistical Manual, or the DSM, of mental disorders. So this is the reference that's most commonly used. To diagnose developmental disorders, it contains criteria for the diagnosis, not only of psychiatric or mental illnesses, but also for neurodevelopmental disorders. The WHO International Classification of Diseases, especially the latest one, the 11th edition, likewise contains definitions of these developmental disorders. However, the ICD-11 does not specify criteria. What are the interventions for developmental disorders? Interventions are based on the profile of the disability, the possible cause, the diagnosis, and the prognosis. Now, this can differ from one child to the other. So, this can also include medical interventions such as workup or medication, home interventions such as parent coaching and parent training, and therapies such as occupational therapy, speech therapy, physical therapy, and school interventions such as coordinating with teachers as to how to accommodate the child in the classroom and also what kind of school the child is best placed in. So now let's talk about autism spectrum disorder. When I was a medical student, we never talked about autism. And even when I was a pediatric resident, this was considered a rare case. But in these times, we have to discuss it even when you're still a medical student because this is already getting to be more prevalent. So autism is a manifestation of atypical development of the immature brain. It is defined, as mentioned earlier, by a set of behaviors rather than a biological laboratory or neuroimaging result. There's a wide range of severity. That's why we use the term spectrum. And as mentioned, there has been an increasing number of cases in recent decades. Particularly in this figure from the Centers for Disease Control in the United States, it just shows us that from the year 2000 until the year 2010, and this figure isn't even updated, there's been a sharp increase in the prevalence. So as of 2008, there is 1 in 88 kids that who is diagnosed with autism spectrum disorder as compared to just 8 years prior to that when the prevalence of ASD was 1 in 166. There are two key areas of manifestation. There's social communication and there are repetitive behaviors or sensory hyper or hyposensitivity. Let's talk about their deficits in social communication. This is really their weakest area in development. And it manifests initially as poor eye contact and the failure to initiate or respond to social interaction. So even when they're just infants, parents often relate how they're less responsive compared to the other children. Language is delayed or may regress. And although they may speak in words or sentences, most of what they say appear to be just talking to themselves or reciting what they hear from TV or echoing what they hear around them. And they often do not converse or respond conversationally to other people. And there is a lack of variety in facial expressions and a lack of use of gestures or nonverbal communication. There's also a difficulty in adjusting the behavior to suit social context. But this is a manifestation of the social impairment that can be seen in older kids as the social demands increase. So if we watch this child, he's quite interested in the knobs of the dishwasher. And it makes him so happy that he claps his hands and he twirls around. Notice that when he is twirling around, he has side gazing or he's looking to the side. So this is often an example Although not seen in all cases, it's quite common among kids with ASD, the side gazing, the twirling, and the flapping of the hands, especially when they're happy about something. So he's quite fixated also about the knobs on the dishwasher or probably the sound of the dishwasher. So there he goes again. He slaps his hands whenever he plays with the knobs of the dishwasher and he keeps going back to the dishwasher.
Say hi.
So that's an example of what we call stereotypical behavior, or what to us may seem purposeless, repetitive movements and activities. But to the child or the individual with autism, this stereotypical behavior often makes them happy or calm. So that's usually the purpose. They can also have unusual preoccupations, and they have this need for sameness and predictability. So they often like to, let's say, line up toys or pile objects or group together certain types of things or colors. And they often resist change. So if they have routines, they get upset if their routine is not followed. And then we often see unusual sensory reactions. It can be a hypersensitivity to some sounds, such that you would see them covering their ears to something that to us is normal. Or it can be a hyposensitivity, such as when the child does not seem to feel much pain to an injury. So going back to Eric now, remember that he's hyperactive and he does not respond when called. So this seems to be, especially with the poor eye contact and interaction, a deficit of social communication. He speaks because he can name colors, shapes, and letters, but he does not communicate his needs. So it's still an impairment in communication. And then he likes to collect yellow pencils and line them up. And this appears to be a fixation or an example of a repetitive behavior. So in this case, going back to the original question, if Eric has special needs, it appears that he has red flags for autism spectrum disorder and requires further specialist evaluation. So why does ASD occur? Unfortunately, no one can definitely answer that as of the moment. So despite the many researches around the world as to the cause or the etiology of ASD, it's still not so definite how this occurs and why the prevalence has increased in the past recent decades. But it is widely believed that there is genetic predisposition. So for many of our patients with autism, they do have relatives who have also been delayed in language, although not necessarily cases of autism. After the genetic predisposition, there's believed to be an environmental trigger, although what this trigger is still not so clear. Some studies have shown an association between ASD and environmental triggers such as fever during pregnancy or exposure to heavy metals and some other illnesses during pregnancy. This leads to a typical development of the brain structure and function such that the child will now manifest with autism spectrum. So for now, we know that autism is an inborn disorder, meaning that we're talking about how the brain developed while in the womb and in the first years of life. So attributing the cause of ASD to things like vaccine doesn't really jive with this framework. What are the general management principles in ASD? We advocate for early childhood therapies for behavior and language, and this is often called early childhood intervention or early intervention because we see that among kids who underwent therapy in the first few years of life, they do seem to have better prognosis compared to those who did not undergo early intervention. So this harkens to what we believe is true about brain development, wherein during the first 5 years of life, there is still a lot of brain development going on. And so if we intervene during this time, we can really maximize the potential of these children. We also do social skills training such that they need exposure to typically developing children. And then school placement is based often on intellectual ability. So not all of them belong to special education settings. Many of them can be enrolled in regular school settings as long as there's support for their needs. And there's the option of medications for irritability, aggression, or attention problems. Let's now go to the case of Gino, who's 8 years old. Gino is also hyperactive. He's unable to stay put. He's in grade 2, but he frequently disrupts class by talking and throwing paper at his classmates. He carelessly answers his tests and thus has failing grades. And then he has several episodes of punching a classmate whenever he is teased. At home, he frequently says that he is bored and he is unable to do homework for long periods. So, is this a child with special needs? Isn't hyperactivity normal among boys? So, we often hear this in the clinic when moms say, he's a boy, so he's expected to be hyperactive. Again, we're going back to the spectrum of severity. So, is this a variation, a problem, or a disorder? Again, if it's a variation, then we talk about age appropriateness of the hyperactivity. So we know, for example, that normal hyperactivity in the development of the child peaks at an age of 2 to 3 years old when the child is developing gross motor skills. But thereafter, hyperactivity does wane, such that the children who are 8 years old can manage to sit for long periods through class with breaks in between. And if the child is hyperactive, if it's normal variation, when it's time to do classroom work, he should be able to settle down and focus on the work. It's a problem if it's causing some impairment or dysfunction. So in Gino's case, it is clear that it is causing some impairment or dysfunction because he already has failing grades. And he gets into trouble. He punches classmates who tease him, and he has difficulty studying at home. It also seems that in Gino's case, this has been going on for several months because he already has grades that show that he's failing. So, is this a disorder? Is it causing serious developmental difficulties? Is it enough to fulfill criteria for disorder? So, what are the criteria for this possible disorder? We're looking at the possibility of attention deficit hyperactivity disorder, or ADHD. Again, this is a neurobiological disorder that interferes with an individual's capacity to attend to tasks, so this is called inattention or attention deficit, to regulate his activity level, and this often manifests as hyperactivity, and to inhibit behavior, this is called impulsivity. in developmentally appropriate ways. So, as mentioned, if you are 2 years old, you can be developmentally appropriate in the sense that you can be hyperactive, you can be stubborn. But if you're 8 years old, our developmental expectations for that age also are different. So, it may no longer be appropriate to do those things. So these are the criteria set in the DSM-5 for inattention. So a child may manifest with failing to give close attention to details or making careless mistakes, difficulty sustaining attention in tasks or play, not following through on instructions, easily sidetracked, difficulty organizing tasks and activities, avoiding tasks that require sustained mental effort, and losing things because they're so forgetful. So, do you think you have these manifestations? Some more manifestations. For hyperactivity, the child can be fidgety, leaving seat when remaining seated is expected. He runs or climbs where appropriate and is on the go or uncomfortable being still and talks excessively. For impulsivity, the child blurts out an answer before the end of the question, has difficulty awaiting his turn, and often interrupts or intrudes on others. The DSM-5 also sets other criteria, such as that several symptoms should have been present before the age of 12 because, again, this is a developmental disorder. So it should be present in childhood, and several symptoms should be present in more than two settings, more than or equal to two settings, meaning, like in Gino's case, there are symptoms seen in the school, and there's also a difficulty seen when studying at home. So they're present in two settings, and the symptoms should interfere with functioning. So there should be evidence of dysfunction, such as failing grades, or difficulty in maintaining friendships or social relationships. So, why does ADHD occur? Heredity plays a role. There's a 30% chance that there's a relative of a person with ADHD that will have the disorder. And there's brain dysfunction. So there have been a lot of studies about ADHD brains seen in functional MRIs or other neuroimaging studies that show that they really have some differences in terms of size and weight of certain areas of the brain. So, especially the frontal brain, which has the role of regulating attention and activity. Unmanaged ADHD can lead to complications. That is why we really need to identify these kids early so that we can intervene and prevent these complications. What are these complications? So early on, there's ADHD only, but as they grow older, they can have disruptive behavior, and later on, they can have oppositional defiant disorder or a learning disability. And then when they're adults, there's the possibility of going into substance abuse or dropping out of school or extending school. And they're also at higher risk for things like anxiety, depression, conduct disorder, and complex learning disabilities. What are the general management principles in ADHD? We also do therapy, especially in early childhood or the preschool years, for behavior training to develop their attention span, planning, organizing skills, and study habits. So it's widely recommended that for kids around 4 to 5 years old, if they're deemed to have a risk for ADHD, they undergo behavioral therapy first. And then later, when they're 7 years old and above, they can be candidates for both behavioral therapy and medication. So there's medication to help improve their focus and self control. We also need to provide them with an outlet for their excessive energy and provide classroom accommodations so that they can function better in school. We also need to address learning gaps because they may not be fully attentive during class and may miss out on some important school concepts. And we need to train their parents as to how they should respond to their behavior at home. We often advocate positive reinforcement rather than frequent scolding or frequent punishment because the negative reinforcement has been shown to lead to more complications later on, such as oppositional defiance disorder. Now let's go to Ella, who's 10 years old. Ella is unable to sit still. She frequently teases her classmates. She does not finish writing tasks and has poor handwriting. She can read only CVC words or consonant vowel consonant, three-letter words, but still has several mistakes. So this is quite remarkable for somebody who's already 10 years old. But she's very talented otherwise. She's very good in singing, dancing, and she seems to function normally at home. So here we have another child who's still restless, much like Gino earlier. But what's different about Ella's case is that we know that she already has learning difficulties because she can read only three-letter words with mistakes, and she can't finish her writing tasks. We're talking here about the possible specific learning disorder. This is an unexpected, specific, and persistent failure to acquire academic skills despite having normal intelligence and conventional instruction. When we say unexpected, this is because otherwise the child seems to be functioning normally and has normal intelligence for practical things. And so if we say that how come this child is unable to read when she seems otherwise normal? It is specific in that same sense as opposed to a general difficulty. So when we say general difficulty, in all areas, whether practical, academic, or other areas of development, the child really has difficulty. But in this case, for a specific learning disorder, there are only specific areas of difficulty, most commonly just reading, spelling, or math, or other academic areas. So this often refers to a reading disorder, more commonly known as dyslexia, a math disorder, more commonly known as a dyscalculia. So when we say specific learning disorder, that's a term being used in the DSM-5. It's like a medical term, but the dyslexia and dyscalculia is more like a layman's term. So this affects about 5 to 10% of school-age children. Dyslexia is characterized by a problem in finding correspondence between graphemes, or the basic elements of written language, and their corresponding phonemes, or the basic elements of spoken language. And this can be associated with attention problems. That's why you have restlessness and inattention, clumsiness, poor handwriting, and math difficulties. So, in the same person, you can have both a difficulty with reading and also a difficulty with math. So, for example, for the word dog, when we're asked, what is the beginning sound of the word dog, most children who are around 5 to 6 years old can already isolate that the beginning sound is a letter D or a letter D with a sound D. But in dyslexia, they do have a difficulty in separating these sounds and correlating them to the written letters. That's why they often reverse whole words or letters. So when they write, they can reverse the letters or even the whole words. Or some of them even claim that what they read just seems like Greek or a foreign language. So in DSM-5, these are the criteria for specific learning disorder. This is defined as having difficulties in learning and using academic skills in at least one of the following. It can be word reading, it can be understanding the meaning of what is read or reading comprehension. It's, it can be in difficulty in spelling, written expression, number sense, number facts or calculation, and mathematical reasoning. There has to be persistence of at least 6 months despite the provision of targeted interventions. This is very important in diagnosing specific learning disorders. They have to undergo at least 6 months of targeted interventions first because more often than not, the child's difficulty with academics is not due to a specific learning disorder, but just due to a lack of adequate instruction. And the skills have to be quantifiably below what is expected for the age, and they have to interfere with academic performance. So this disorder begins during the school age years, again harkening back to developmental disorders. Manifestations of developmental disorders, including specific learning disorder, have to begin in childhood. And these are the exclusion criteria, meaning it should not the same as intellectual disability. If the child has a general slowness of development, then it's better diagnosed as intellectual disability and not specific learning disorder. So they do not coexist. It shouldn't be due to uncorrected visual or auditory problems because you may have reading difficulties because you cannot see the words. You have vision problems. So it cannot be called a specific learning disorder if your difficulty is purely due to the vision or auditory problems. It should not be because of mental or neurological disorders, psychosocial adversity, such as poverty and lack of proper education. It shouldn't be due to lack of proficiency in the language. So if your first language is a foreign language, for example, and you're trying to read English, but you grew up reading, let's say, a Korean language or a Japanese language, then it's quite understandable if you cannot read the English words. And it shouldn't be due to inadequate educational instruction. What is the neurobiological basis? So we know that it is neurobiological because with an affected family member, the risk is increased 8 times for a reading disorder and 10 times for math disorder. So there is genetic predisposition. It usually runs in families. So when I have a child that I diagnose to have dyslexia, for example, in my clinic, I can often trace one or the other parent also having a history of reading difficulties and even current spelling difficulties as adults. There are problems in brain connectivity because some functional MRI studies have shown that there is decreased activation of the left hemisphere of the brain when they're asked to read something, but there is corresponding activation of the same hemisphere when they're just hearing or listening to the same words. And there are no differences in brain activation when they listen. So they actually learn their lessons by just listening to the discussions in the classroom without reading what is on the blackboard. So what are the general management principles in specific learning disorder? For now, there's no definite cure because we're talking here about a difference in brain connectivity. It's not an acute illness that you can just cure with something that you take. But focus is on remediation or teaching them compensatory mechanisms. So retention in grade level is usually not advisable, and we have to give them classroom accommodations. So an example of this would be the teacher will need to read aloud the instructions or the questions for the child to be able to answer according to what he knows. And we have to highlight their talents because they're usually talented in other fields, not related to their academic difficulty. Let's now go to Chessa, our fourth case. She is 9 years old. She has low scores in her exams. She can read words, but still with frequent mistakes, much like our previous case. She survived grade 1 only because of tutorials, but the tutor complains that she easily forgets her lessons, and she easily cries and throws a tantrum in class although she's already 9 years old. And she prefers to play with younger kids, like the kinder students. She usually can't get into what her classmates are into. By history, she was born preterm, and she also learned to walk late at 2 years old and to talk at 4 years old. At this point, I think it would be helpful if we review the normal developmental milestones. So we usually learn to walk by 12 months old. So this child is walking independently at 12 months old. So if Chessa learned to walk at 2 years old, that would be considered already a delay in walking. Going back to our language rule of thumb, at age 1, we usually should hear single meaningful words already. At age 2, two-word sentences. At age 3, three-word sentences. And at age 4, four-word or full sentences. So if Chessa started to talk in words at age 4, that's definitely a delay in language development. If we look at the cognitive milestones, Chessa would probably also be delayed in these milestones. So this is what we call an intellectual disability. As opposed to what we discussed earlier on specific learning disorder, an intellectual disability is a generalized difficulty. It is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits. So intellectual functions include reasoning, problem solving, planning, abstract thinking, academic learning, and learning from experience. So they usually show up in school as having academic difficulties like Chessa. Adaptive functions include communication, social participation, and independent living or self-care skills. So in Chessa's case, we know that she was delayed in talking. and she has difficulty in social participation with same age peers. Intellectual disability has different severity levels. The mild intellectual disability presents as difficulties in learning academic skills and functional use of academics, such as money management. They often have immature social interactions, difficulties in regulating emotions. So, an example of this would be throwing tantrums in an age inappropriate fashion. So, she's throwing tantrums at the age of 9, which is inappropriate for her age. They can also be gullible. They can be independent in personal care but need support in complex daily living tasks such as prioritizing and planning. Moderate intellectual disability are individuals with very slow progress in reading, writing, math, understanding of time, and money. So they usually need maximal support in school for them to learn the basic lessons. As adults, academic skills remain to be at elementary level only. They have limited social judgment and decision making, and they require extended teaching for independence in personal care. When we talk of severe to profound intellectual disability, there's little understanding in the basic academic concepts. They have limited language and they require support for daily activities such as feeding and dressing. So Chess's case appears to belong to either a mild or moderate intellectual disability. What are general management principles in intellectual disability? First, we investigate possible causes, which can be neurologic or genetic. So, for cases particularly with severe to profound intellectual disability, we often suspect genetic syndromes or neurologic um, structural problems. They often need a repetition of concepts, hence the need for tutorials and extended teaching. They need to acquire skills for independent living, and we have to think about the appropriateness of school and level placement. So, do we put them in a special education setting? Can they manage to be in a regular school setting but with support? So when we talk of developmental disorders or disabilities, they have a certain age of presentation. So for example, when we talk of Down syndrome, which is one of the most common uh, cases of intellectual disability, we often identify them at birth because of their syndromic physical features. By infancy, we can identify cases of cerebral palsy. By early childhood, we can identify cases of autism spectrum disorders because they now would not be talking as well as their peers, and their repetitive behaviors would now manifest at that age. By school age, we tend to identify the kids with ADHD and learning disorders. And this also extends now to adolescents. How do we promote development in general, not only for those with disorders, but also for your typical developing children? It's very important to encourage exploration of the environment, especially in the early childhood years, because these kids learn more by playing, looking, touching, tasting, and experimenting rather than by, let's say, watching a TV show or being taught side by side by an adult. There should be a lot of human interaction though, because it's when humans interact with them by playing with them or talking to them that our brain activates for language development and cognitive development. We also should do reading aloud to the child and get them to be used to um, this kind of interaction with an adult. And there should be a lot of active outdoor play. So if you really think about it, if there's one activity that prevents all of these developmentally stimulating activities, what would it be? What activity would prevent a child from exploring, from interacting, from having reading activities, and from actively playing? So can you think of a particular activity? So this is quite common nowadays that children have a lot of screen time. And the thing about screen time is that it kind of becomes an obstacle to developmental stimulation. So if a child is in front of the TV all day or just looking at a gadget all day, especially in the early years, then you would prevent the child from exploring the environment, from interacting with people, and from actively playing. That's why the WHO in 2019 came out with guidelines that there should be no TV or gadgets or sedentary screen time, as they call it, before the age of 2 years old. And after the age of two, this should be limited to not more than 60 minutes per day, and less is better. So we often see this nowadays that children just play together virtually or through a screen, such that they can have sleeping difficulties or they can even be bullied when they're older. And that prevents them from social interaction. So at the end of this lecture, I would like you to remember this very important figure. When there's early recognition of these signs and symptoms of possible developmental disorders, this leads to early intervention. And early intervention is important because it's in the first few years of life that the brain still undergoes critical development. So it's important to intervene in the early years of life. Early intervention promotes better outcomes or better prognosis. So how do we do early recognition? By developmental surveillance and screening. And you learn about this in a separate activity or lecture. How do we do early intervention? These children should be referred to specialist evaluation services early on. And we do developmental monitoring to make sure that the child reaches his best potential. So, as a famous autism individual, Temple Grandin says, they are different but not less. So we should remember this when we try to maximize their potential and develop their skills so that they can participate more in society and society would be more welcoming. Thank you very much for listening to this lecture.